To that end now, Dr. Brewster has agreed to give us a brief update. He was a member of the writing committee of the American Heart Association who recently updated their PAD treatment guidelines, and he's going to give us sort of a 30,000-foot overview on what's novel and what we need to be aware of.
Thanks, Bjorn. Thanks, Misty. It's a real privilege. The VES is, as we know, one of the awesome societies, and I think one of the things that we're going to highlight here is how involved and impactful our members are. This is a slide from Alan Hirsch. He said never to share it, but he has now died, so I share it almost every time. And I think it beautifully highlights how interesting PAD is. I know that the experts here can shed a lot of light on that. This is how I want to say thank you to all the presidents that allowed this. I sent the email when there was an email call back on May 12th of 2020 and was notified that year that I got to be the VES representative. And then the guidelines came out last year. So 4 years of being quiet and not being able to talk about them as we are secluded. But really an awesome thing. So please take advantage of these when they come out. This is the author group. You'll see a number of our VES members here. I saw a number already today. And it's a multidisciplinary group. You see VES and SVS. You have SIR, SVN, and SVM. Lots of acronyms. This is the first email that went out. Heather Gornick was the overall guru. She's amazing. She's been here, I think, talked about vascular lab and credentialing and a number of other things. She's amazing. This is how we were sorted out at the beginning. And then we spent about 2.5 years knocking out things and finding data and updating the data. And one of the sad things that you're going to see is that we need more data. And so I'll finish with some call to that data. This was my favorite slide of the outline, and I think a number of folks here really can put this together for us, and a lot of the talks speak to it. But it shows the interaction of a number of things, both biologic and societally, that impact this and change what happens to our patients. I think the Loyola presentation of homeless speaks to this as well, that everybody comes in different, and some of these folks come in with infection, and some of these folks really have the PAD. And this is one of my favorite things. We have a lot of Class 1 data on smoking cessation. I know that we really engaged there. And for those of us lucky enough to be in a VA system, we can actually refer folks to get some help in this situation. But this was probably the most level 1 data. The diabetes data, I just wanted to highlight some of these new medicines. I probably can't do it well. Can cause all kinds of problems. We had an incident with, and I'm going to totally goof it up, the empagliflozin, and it can cause a metabolic acidosis that's a non-gap, and so it's supposed to be stopped 2 days to 5 days before we do an operation. And we just had a patient have that, and I had no idea. They tried to write up one of our surgeons. I said, no, we don't stop the diabetes medicines. The primary and the anesthesia folks help us with that. But I thought that was worthwhile pointing out. Then goes through medications for chronic symptomatic PAD. You can see that we're still in this world of silastazol. For those of you who like silastazol, I think it's 20 meters is what you get. So I kind of tell my patients it's a bunt single. But for those of you doing research, there can be some real opportunities here for translation. The preventative foot care, again, speaking to the Loyola presentation, really important to have this team. And if you are lucky enough to have the podiatry, it's awesome. If you do not, finding partners that can help with that. Again, lots of Class 1 data for helping these folks not undergo amputation. This is crazy slide, but 4 things saying that SET is good. And then for those of you in the know, we've equivocated supervised and structured. Structured is much more achievable for most of us, and can have benefit. I think it's an area of active investigation. There are paradigms for learners in the audience. You can wow your faculty with the different paradigms. And one of these is for claudication, and then the other one for CLTI. When you were talking about REVASC for claudication, lots of emphasis on knowing the patient, figuring out the goals, and getting buy-in. I know that we all know this, but that's really where the Class 1 data is. Then the REVASC showing the benefits from the CLEVER trial, where we have REVASC and integrating that with other things like structured exercise. The REVASC from claudication with femoral disease is pretty weak, and I know that we have a lot of wins, but for claudication proper, it really hasn't been studied. So for people interested in that, that is a gap that we can certainly contribute to. And then I love this, REVASC for claudication and for POP, unknown. I think another area of where we could help people and hopefully restrict some care that may not be as helpful. Team-based care, I think we're in on it. We have the multi-specialty care team that I think a lot of our groups have moved to, and then trying to get folks to that end game. There was a lot of interesting feedback that we got from our reviewers, largely kind of trying to get out both Basel II and best CLI and getting some sort of recommendations. It basically led to a firewall. So for those of you with university and VA appointments, you know that what happens over here has no bearing over here, and that's basically how it went down in the guidelines. And then the no option really focused on trying to prevent amputation or delay it. And then the amputation work is really underdeveloped, I'd say. I think it's a great field. It's certainly a place where a number of people have been leaders, and we heard Ann earlier. And I think it's also a place where vascular surgeons can really be involved. And then the longitudinal follow-up of PAD, I think it's something that people really don't understand that we provide, but it has a whole lot of value. And the bottom one is the 2A, and that's something that our group always argues about, and that's with respect to imaging non-vein grafts over time. These are the gaps that are identified, and a lot of it really goes to the immense data sets in cardiology that then are subsetted for PAD. And again, I really think it really speaks to people and who are interested in getting clinical trials and getting groups together that a lot of this data needs to be developed. My own interest, reviewers from our VES, these are some of the people, they have to publish your name, but Dr. Zalaby, Boulou, and Velasquez. So thank you there too. So we had writers and reviewers from VES. This is where a lot of my interest is in the differences between men and women. Amy Pollock leads the PAD Coalition now, and this is stuff that we started on 12 years ago. I think, Jeannie, were you a fellow back then? All professor now. And then looking at these presentations, it's astonishing that we don't have more data here. and I think it's an area of interest. These are some of the leaders in PVD Council that help move this forward. Esther Kim on the far right is our current chair, and she's made this the focal point of her time. And finally, my bride and I got engaged on a trip to Breckenridge, and so this place always makes us want to be here. So I'm very grateful to the program committee and everyone else for allowing us, and fitting to all football coaches at the end of halftime, go Chiefs.